My name is Jeannie Hoffman. I'm a rehab psychologist here at the University of Washington Medical Center and the co-director of the Northwest Regional Spinal Cord Injury System. Tonight we are very pleased to have Dr. Michael Stillman with us. He's a primary care physician who is an expert in primary care for people with spinal cord injuries. And tonight he has offered to talk to us about working with your primary care doctor and how to get the most out of that experience in terms of accessible, appropriate, and timely medical screening and services for maintaining your health. So please join me in welcoming Dr. Stillman.
Thank you. Can everybody hear me? More importantly, can everybody understand me? I grew up in Massachusetts, and it never strikes me that I have any sort of accent, but people often tell me I'm difficult to understand. So if anybody has a problem, just yell out, and I'll try to clean it up a little bit. So again, my name is Mike Stillman. At least for the next few days, I'm a clinical associate professor of internal medicine and rehab medicine here at the medical school. As some of you may have heard, my husband Steve Williams and I have taken positions in Philadelphia, so we're leaving next week. So this is kind of my swan song to the department. But I really am delighted to be here with you all this evening discussing the most general of general medical concerns for people with spinal cord injuries. And with that in mind, we really have three goals for this presentation. These are listed in no particular order, but we want to open a discussion about what you ought to expect, reasonably expect from your primary care team. We want to talk about what testing in preventative care and preventative measures you ought to expect to receive as part of routine care. And I also want to touch on issues of accessibility, particularly in outpatient medical facilities. And I just want to remind everybody here, and many of you may be aware of this, of what your rights are when seeking health care as a person living with a disability. So does this seem like a reasonable agenda? Is this kind of what everybody was expecting? Good. And how is it that I was picked to give this lecture tonight? Well, as Jeannie mentioned, I'm a primary care doc. I did a residency in internal medicine, not in physiatry. I came out of residency in 2004 and practiced kind of regular primary care for about 10 years. And then several years ago, I developed a niche academic interest and practice focus in helping care for people with chronic complex disabilities and spinal cord injury. And I've been doing that for the last several years. So although I don't have any formal training in the area, as many of my colleagues in this department do, I've read a good deal, and by this point I have a good amount of hands-on experience. And I think most importantly, I've been instructed at the apron strings, if you will, of some of this country's finest spinal cord injury physicians, including my husband Steve and Steve Burns here at the VA, and Rena Reyes, who many of you may know is on faculty here and is just a tremendous, intelligent and compassionate physician. So I've gotten really good instruction from these people who have been wonderful mentors to me. And now this is the mainstay of my practice. I do some general primary care and do take care of some folks who don't have disabilities, but most of the work I've been doing here for the last year has been in the rehab clinic on the 8th floor, and it'll be at least half of my practice in Philadelphia. So that's my background, and that's how I wound up here with you this evening. We thought it would be interesting to start this evening's discussion just reviewing what is known about primary care for people with spinal cord injuries. And as you can imagine, that's a very complicated discussion. And it can take many different facets. There are really many different ways to approach that discussion. So this may seem like a buckshot approach, but I'll tell you what I know and what I've been able to discover from the literature. So first of all, there's a controversy over from whom most people with spinal cord injury tend to seek most of their medical care. There was a study out of New Jersey about 10 years ago. They surveyed 199 folks living in that state with spinal cord injuries, and they asked them who they considered to be their main doctor type, their primary care doc, if you will. And my heart sank when I saw this, but 60% of respondents said that it was an SCI specialist, a physiatrist, not a primary care doc like me. The other 40% referred to a primary care doc. But about the same time, there was a study out of the Craig Center in Colorado, and this study is a pretty comprehensive snapshot, if you will, of outpatient medical care for people living with injuries. And what we found is that 75% of respondents said that they actually have a primary care doc. 65% of respondents said they have an SCI specialist who helps care for them. And really, they would go to each one of those doctors with a different set of concerns. So I think that study probably showed us really more what the reality is for most people with spinal cord injuries seeking medical care. I think many people with injuries kind of get a patchwork of care. They have many different physicians who help take care of them. They get certain services from some doctors, certain services from other doctors, which may be different from the experience of people looking for medical care who don't have spinal cord injury. We know that people with SCI tend to be what we call heavy utilizers of medical services, both inpatient in the hospital and outpatient in the clinic. There have been a couple of studies looking at rehospitalization for people with spinal cord injury. Diana Cardenas, who used to be on faculty here and is now in Miami, did some important work in that area. Jeannie has done some very important work in that area. And we know that people living with injuries are at much higher risk than people without injuries for rehospitalization, even years after their injuries. But we also know from a study that Steve and I started at University of Louisville, and I'll tell you a little bit about this, that even in the outpatient setting, people with SCI tend to have about twice as many visits to outpatient physicians as do people who are not living with spinal cord injuries. And I'm going to break here and just tell you about that study because I'm going to show you some data from it. So we did a study when we were at University of Louisville with a couple of colleagues from the School of Engineering, and we developed a survey meant for wheelchair users, and we distributed via the internet. And we had help in the distribution with a couple of national organizations that help care for people with disabilities or help serve people with disabilities. So we got about 430 responses from wheelchair users nationally. And we did what's in the research world called a subset analysis. So we looked at the answers specifically from people who have spinal cord injury. 430 responses from wheelchair users, 108 responses from people with SCI. And again, it turns out that the people who responded with SCI make about twice as many physician visits as people in this country without SCI. And then we also know that people living with injuries have difficulties finding physicians who are adequately knowledgeable about how to care for people living with disabilities. And I don't think I need to convince anybody in this room of that. I can tell you that there have been a couple of studies looking at this, both from the patient's perspective and from the physician's perspective, but I think it's probably obvious to many people here that that's the case. So what else do we know about primary care for people with spinal cord injury? We know that there have been pieces of landmark legislation that were now passed as many as 40 years ago that were meant to make public accommodations in this country equally accessible to all Americans. I'll mention them later specifically, but you all probably know about them. And we know that despite those laws being on the book, medical offices tend to be very inaccessible to people with major mobility disabilities and people living with disabilities. This is a significant ongoing concern. In that study that we ran out of University of Louisville, we asked our respondents about specific physical barriers, so not attitudinal barriers, but physical barriers they confront when seeking outpatient or clinic-based medical care. And I'm going to share with you some of the answers. So this slide shows the responses of all 430 people who were wheelchair users in the community. And what you can see is that we broke down potential physical barriers to the facility level, that's the building in which a medical office is housed, to the clinic level, that's the medical office itself, and then to the level of the examination room itself. And these numbers are terrible. You can see that 20% of respondents said that their outpatient medical offices lack accessible parking. You can see that about 30% of people said that the exterior doorway to the facility, again, the building in which their medical office is housed, was inaccessible to them. You can see that width and accessibility of clinic doorways and hallways and restrooms was a concern to a great number of participants and respondents. But look at the preponderance of examination room barriers. So 20% of people said the room itself was inaccessible to them, maybe inadequate door width, maybe inadequate turning space, inadequate space next to the examination table to permit safe transfer onto the table. 50% of people said the examination table was inaccessible to them. They couldn't get it on and off the table. 40% said there was a lack of transfer aids in their medical offices, and 30% said that there was a lack of transfer assistance available to them. These numbers are terrible. These numbers represent the reality with which many people with spinal cord injury live when they seek medical care. And if we really think about this, and again, I wouldn't have to challenge many people in this room to think about this, but when I think about this, this is a picture of inequitable health care in this country. This makes me angry. I told you we did a subset analysis from our respondents who were living with spinal cord injury, 108 people across the country with SCI. And we asked them specifically what happens when they go to their primary care doctor's office for an examination. The same, approximately 21% said that their primary care doc's office lacked accessible parking. Shocking. Every strip mall in this country has accessible parking. Apparently a fifth of our primary care offices don't. About a third of respondents said that they couldn't open the door to the clinic. There were no hand swipes. 77% reported that the examination tables were inaccessible to them. 70% reported that there was no transfer equipment available to them, and nearly 45% reported that there were no staff able to safely assist them with transfers. Again, terrible numbers. We know that people living with SCI don't tend to get the screening or preventative care that they ought to, that we all ought to expect from our medical teams. There have been a couple of studies looking at this. The best known was by Sherry Lavella in 2006. Some of you may know of this woman. She's a big researcher in the VA system. I believe she has a faculty appointment at RIC in Chicago, but she's very well published. This is one of her best known studies. This was an elegant little study she put out in 2006. She had two groups of female patients. As you can see, some of them had spinal cord injury, some of them did not have spinal cord injury. They were what we call in the research world well matched, these two groups of patients. So from the socio-demographic perspective, they looked very similar. Similar ages, similar family incomes, similar disease burdens, other than the spinal cord injury. And importantly, they were all getting their care in the VA system. So for the differences in the care they received, you couldn't say, well, some of them were getting their care in this hospital, maybe there's a local difference in standard of care there. They were all getting their care in the VA. And what you can see is that the women who were living with injuries received significantly fewer dental appointments and appropriate screening tests for colorectal, breast, and cervical cancer than the women without injuries. In our little study of 108 people with spinal cord injury, we asked similar questions about receipt of preventative care, and what you can see is that the women in particular with spinal cord injury receive significantly fewer screenings for cervical and breast cancer than do women nationally who don't have spinal cord injury. And then finally, we know that people with spinal cord injury get terrible physical exams by their physicians, specifically by their primary care docs. I won't implicate the physiatrists in this. I think they actually do a pretty good job. Now, I'll share with you a bit of data from our study out of University of Louisville, but again, I don't think this is something of which I have to convince many people sitting in this room and in the audience. In our study from University of Louisville, we asked our respondents with spinal cord injury what happens when they go to their primary care for an exam. How are you examined? 85% of them said they were examined while fully clothed in their street clothes, and 90% of them said they were examined while they're still in their wheelchairs. Now, when those numbers came back, I was horrified, and I kind of couldn't stop thinking about them and talking about them. And I discussed those results with a couple of colleagues and friends with spinal cord injury, and some of them, well, they didn't seem that surprised by them, but some of them maybe defended that practice by primary care docs, and they said, you have to understand, Mike, that for people living with injuries, particularly people with motor complete or higher level injuries, it's really hard to get changed into a gown in a physician's office, and it's really hard to get transferred onto a table and back into your chair, so maybe that's not the worst thing in the world. My responses to that are this. First of all, yes, I validate that. That is true. Okay? But beyond that, I would say, if you come into my office for what I would consider to be a relatively straightforward concern, let's say you have shoulder pain, right? I can examine you while you're in your wheelchair. I'd want to look at the shoulder joint, get your shirt up, make sure you don't have herpes zoster or something like that. I'd want to look at the joint to make sure there are no derangements. But I could do an adequate exam while you're still in your chair. But if you have a more complicated concern, if you have hip pain or belly pain, or if you're having autonomic dysreflexia and the reason for it isn't immediately obvious, you need and deserve a comprehensive physical exam. Physical exam is not dead. It tells clinicians an awful lot. And I also think, and this is just my own practice, I have no data to support this, once in a while, I like to get my patients with spinal cord injury changed into a gown and get them up on a table and do a full physical exam on them. Now, I don't do it necessarily every 12 months, but maybe once a year, thereabouts, maybe every 16 months. I just keep it in mind that I ought to do it once in a while. What's the reason for that? Is that it's hard for me if I examine somebody with a spinal cord injury while he or she is still in a chair to get a good listen to the bottom of the lung fields. I can't do a complete cardiovascular exam while somebody's in his or her chair. I can listen to the heart, but I can't listen to the big blood vessels in the belly or the groin or assess peripheral pulses, if that's blood flow to the legs and to the feet. I can't do a good skin check. Now, many people living with spinal cord injury know when they have problems with their skin, they can tell me where they have a pressure point or where they have potential breakdown, but I sometimes like to examine people's skin and make sure that they don't have any suspicious lesions that need further evaluation. So I think once in a while, everybody, whether or not they have a spinal cord injury, deserves a complete physical exam. And it seems to be that people with SCI aren't getting those. All right. So this brings me to the role of the primary care doc. And again, who better to speak to this than a primary care doc? And I've thought a lot about this. The role of the PCP, it seems to me, has changed a lot over the last 20 years. So it used to be, back probably before I went into this field, that internists, what we now consider primary care docs, were kind of the royalty of the medical profession. You know, we were the first line diagnosticians. We knew a lot about a lot. People really turned to us in their time of needs. And then with the advent of HMOs, physicians for a while, or primary care docs for a while, became what were called gatekeepers, and insurance companies were turning to us to prevent people from going to see more expensive specialist physicians, which is a terrible position to put physicians in. And then there was this advent, as some of you have heard, of the medical home, and so now primary care docs are considered kind of the quarterbacks of your care. You know, we make sure you get the screening tests you need and the vaccinations that you need, and we're kind of your first contact, or at least somebody in our office is your first contact. So there's been this evolving understanding of the role of the primary care doc, but I would call for a more nuanced understanding of that. I think when a primary care doc is caring for somebody, particularly somebody with a complex set of medical conditions, it behooves us to really kind of sit down with you and listen to you and try to understand your medical concerns. To do complete reviews of systems, as we call them, to make sure that we're asking you head-to-toe questions about your health, to make sure that we understand not only your medical needs, but your social needs, what equipment you need at home, what kind of support you need at home, what your transportation needs are. We really need to understand you in a more thorough way and not simply refer you on to other physicians or caregivers who can do that. So I think PCPs or primary care docs really owe you that. And part of that is relying on our diagnostic ability. Now, I don't have any data to support this, but I know that a lot of primary care docs are intimidated by the prospect of taking care of people with spinal cord injury. It's because we don't get a lot of training in how to care for folks living with disabilities. And in that way, when somebody with a spinal cord injury comes in to see us with a medical concern, we do one of two things. Either we just refer them to somebody else, we refer them to the physiatrist or to the urologist or whoever, or we necessarily and sometimes inappropriately ascribe your medical presentation or your medical concern to your spinal cord injury. And people with spinal cord injuries have medical problems that have nothing to do with their spinal cord injuries. So I think, again, a PCP really owes it to you to utilize his or her diagnostic abilities and to really try to diagnose what's going on with you, whether or not it has to do with your spinal cord injury. And one of the benefits of that is that will help unburden your specialists. So, you know, Jeannie and I have been talking about this, and Steve Williams and I have been talking about this. There are 600 physicians in this country, give or take, every year, who are specialized in caring for people with spinal cord injury. 600 of them. And this is an enormous country, and as many as 1.5 million Americans are living with SCI. And many of those specialists live and work in big cities or in cities with academic centers like University of Washington, where there's great specialty and specialization in SCI. So I wonder what happens to people living with injuries in more rural areas or even in big cities that don't have an academic center like University of Washington. And I think the answer is that they don't get a lot of support from people who are really expert in caring for people with spinal cord injury. So again, the care of people with spinal cord injury, I think, ought to be mostly assumed by primary care docs. And we need to know that we have backup when necessary, and we need to be humble in asking for that. What should you expect from your primary care doctor or from a primary care team? Well, first of all, advocacy. Many people with spinal cord injury have a lot of needs, medical and not specifically medical, and it ought to be your primary care doc who asks you about that and who helps get you what you need to live your life as fully and as independently as possible. Availability. This is a notion that's changed over the last 20 years. So when I came out of residency, availability meant I had a beeper on my belt all the time, and I was on call every other night for many years running. That's not the case anymore. There are different ways for us to be available to you. In this place, residents take first call in the clinic, which, you know, unburdens us in the evening time. But in centers like University of Washington, we have the electronic medical record, and we ask patients if they will enroll through the electronic medical record in something called a portal, whereby you can directly contact your physician with concerns. Now, obviously, that's not to be used for medical emergencies, but if you have something that can wait a day or two, it's a good way to reach out to us. Humility and curiosity. Primary care docs need to be aware of what they do and do not know about the care of people with disabilities and spinal cord injury. And they ought not be bashful about admitting that, but if they do admit that they have a knowledge gap, they have to be hungry for knowledge, and they have to be curious. They have to be willing to go read and to go consult with colleagues, to reference the literature. They have to want to learn more about your condition and how to keep you as well as possible. Communication, I think, is critically important with you as the patient, with other providers. This is absolutely essential to taking the lead into quarterbacking your care, if you will. And a corollary of that is that more and more, I think it makes sense for people, and particularly for people living with complex disabilities, to try to keep their care in a single system. Now, you wouldn't have caught me saying that 5 or 10 years ago, and I will tell you all that I'm not necessarily a partisan for UW. I happen to think this is a great hospital system, and I'm very proud of the medical care that's delivered here, but I think people have good options. You know, this is a city that's fortunate to have, I think, 3 really top-shelf hospital systems. So if you get your care at UW, that's fine. If you get it elsewhere, that's fine. But I think it makes sense to keep as many of your medical professionals in a single system as possible. Why is that? It's because the electronic medical record makes it very easy for me to reach out to a whole team of physicians and to make sure that we're coordinating care for you as best as possible. I had a patient I saw a couple of weeks ago who was working with a gastroenterologist, a Swedish, who I needed to talk to. I had to call that gastroenterologist's office 3 times over a week, and I had to remind myself to do that just to get some basic information. But here, all the information's on the medical system. If it's not, I can just drop one of the other physicians a note. So again, I think that's something to think about. And then accessibility of outpatient medical offices. What are your expectations for accessibility? Now, I had referenced a couple of pieces of landmark legislation that are by now very old. They've been on the books for many decades. One is the Rehab Act of 1974, and one is the Americans with Disabilities Act of 1990. And both of these laws, in their own way, try to ensure that public accommodations, specifically including medical facilities, are equally accessible to all Americans. And I have to say, there's been a failure of enforcement of these laws. But that doesn't mean they were not well intended. They absolutely were. It's just that we as a society have not done well enough. So given the facts on the ground, and those facts are that many medical facilities are not wholly ADA compliant or not adequately accessible, you all have to ask yourselves, with what are you able to live? What kind of medical facility will give you as close to comprehensive and thorough care as you can get? And this is what I would suggest to you. I'm going to give you a little insider secret here. There's something that you can ask for if you're thinking about signing up with a new physician called a face-to-face. Has anybody heard of a face-to-face? You have? Really? Are you all in the medical field? Okay. So a face-to-face is this. Like, people are going to kill me for letting loose with this. You should be able, before you sign on with a physician, to go meet with him or her and interview that physician, and if you want, his or her staff. You ought not be charged for that. Your insurance company ought not be charged for that. This is not an official doctor's office. So you can go in and you can interview them. You can do it by phone, but traditionally we go and meet each other, right? And there are certain questions that I would suggest you ask any physician with whom you're considering working. First, and we touched on this a little bit earlier, how will you examine me? We know that most primary care docs examine folks with SCI while they're in their street clothes in their wheelchair. Say to this doctor, are you ever going to be able to give me a full physical examination outside of my chair and outside of my street clothes? How will I be accommodated in your office? You can ask that question. You can go poke around the office. Make sure that you fit into all the spaces. Make sure you can use the bathroom. Make sure you can get in and out of exam rooms, on and off the equipment. Are you willing to advocate for me? So advocacy is so important when we're helping care for people with spinal cord injury. And you can ask this doctor, tell me what your advocacy has looked like in the past. Do you have patients for whom you've had to advocate? How far have you had to push insurance companies? How hard have you had to fight? Are you willing to do that for me? This fourth question, I think, makes the assumption that this doctor won't know a lot about spinal cord injury, but that's probably a fair assumption. Are you willing to learn the basics of spinal cord injury as we work together? Are you willing to go read a couple of review articles about injuries and about potential secondary complications of injuries just so you can help me be an active participant in my care and make sure that we're both doing good surveillance, making sure that I'm keeping as healthy and as independent as possible? Will you be able to refer me to accessible specialists into referral facilities? This is very important. Even if you find a primary care doctor that you think is peachy and adorable and is going to fight really hard for you and is going to be intellectually curious and humble, if he or she only has available in that network inaccessible facilities, that's of no use to you, right? You need to know that you'll be able to get a mammogram when you need one, or that you'll be able to get to an accessible endoscopy suite if you need a colonoscopy, or that the radiology facility nearby is accessible if you need an MRI. You need to have assurances of that. Will you be able to schedule me at a time that's convenient for me, or that will permit you extra time if necessary? So some primary care docs who have patients with disabilities in their panels will say to them, you get the 1 o'clock appointment. I know it takes you a long time in the morning to get ready to come see me, or I know you have to travel a good distance to come see me. You get the 1 o'clock appointment and I'm going to give you a full hour regardless. Or they may say, you get the last appointment of the day. And that means that you may have to wait a little bit longer to see me, but that's okay. If we go over, it's fine. I owe you that. These are questions you should be asking physicians before you agree to work with them. The next section of the talk is about kind of routine and preventative care. And I will tell you that we're going to start off talking about cancer screening. And much of the data with which I'm going to present you come from something called the USPSTF. This is the United States Preventative Services Task Force. This is a group mostly of physicians. It's an independent group that's tasked by the federal government with once in a while reviewing whatever data are available about different preventative measures and tests. I will tell you a couple of things about the USPSTF. First of all, they never take into account cost of testing. So the USPSTF will never say, this test looks reasonable, but it costs too much, hence we're recommending against it. They never bring money into the discussion. The other thing is that even if some of you have never heard of the USPSTF, you have surely heard of some of their recommendations because some of them have been quite controversial in recent years, and you will recognize them as we discuss them. So the first area I want to talk with you all about is colorectal cancer screening. And there's some young people in this audience, and this won't affect you for a number of years. But for the people more my age, we've got to think about it. So colorectal cancer is not an uncommon cancer. It kills about 50,000 Americans a year. And there are compelling data that say that screening Americans between the ages of 50 and 75 significantly reduces death from colorectal cancer. So there are good studies that show that if you take 10,000 or if you take 1,000 Americans and you screen them from the ages of 50 to 75, you can avert or avoid between 20 and 24 deaths from colorectal cancer. Those are real numbers. Interestingly, despite the fact that there are different tests you can undergo in an effort to screen for colorectal cancer, there are no head-to-head data comparing the efficacy of these different tests. And that's going to be important in a moment when we talk about this. Possible screening strategies that you can consider or you can discuss with your medical team. Annual screening with what's called fecal immunochemical testing. So this is when we test your poop for blood. You get a smear of your poop, you send it into a lab, we develop it, and we look for blood. So, you can send this into the lab, we can tell you if there is blood in your poop or if there is not. And why is that important? It's because sometimes precancerous lesions or cancers themselves bleed into the GI tract, and we can detect that in your stool. So the good thing about this test is that if it's negative, you're done until a year later. If blood shows up, you have to get a scope. So it's only helpful to you if it's negative, right? In a way. Colonoscopy. So many of you know what colonoscopy is. This is when we take a tube with a camera on the end of it, and we give you a very aggressive clean out, which I'll tell you about in a minute, and we insert that tube through your bottom, and it goes all the way around your colon, all the way to where your colon meets with your small intestine. This is a big test. The screening is very difficult. I mean, the clean out is very difficult. This is when you have to drink that gallon of fluid, and we ask you to drink it until, as we say, you poop clear. So you drink it until what comes out your bottom looks exactly what you drank. So there's no poop left in you. And then the next day you go in for the colonoscopy. There's a shorter version of that called a sigmoidoscopy. That tube with the camera only goes this far, maybe only the last 2 or 3 feet of your colon, and you can combine that with that annual testing of your poop for blood. Sigmoidoscopy is easier for people because you get the preparation in the endoscopy suite. They can just get you on a table, they can give you a couple of enemas until you're clear, and then they go in with a scope. So it doesn't involve that huge clean out that the colonoscopy does. And then there's something called the CT colonography. Some of you may have heard that this is a CAT scan by which we can look at your colon. This is not as sensitive for detecting smaller polyps, but it is available to people. At this point, we still have to do the full clean out, but there are studies looking at what happens if you do a CAT scan with somebody who hasn't drank that gallon of fluid and pooped until clear. And then there's some emerging data about combining blood testing for the colon with or for the stool with cancer DNA. And this test is not good enough yet, but I think in the next few years it will be. So I used to be kind of a colonoscopy or bust guy. I always thought that colonoscopy was the gold standard test in looking for colon cancer because they can visualize your entire colon, and I thought it was almost an issue of social justice. People with spinal cord injury should definitely have access to a colonoscopy. I still think that, in part of my being, but what I've come to realize as I get older, I'm a little more sensitive and I'm a little more circumspect, is that for a lot of people living with injuries, that major clean out is a huge burden. People cannot easily, if they have a high level or a motor complete injury, go home and drink a gallon of fluid and have gushing diarrhea for 6 or 8 hours until they're clear. We sometimes electively admit people with spinal cord injury to the hospital just for a clean out the day before they go for a colonoscopy. And that's also a burden. Nobody wants to be in a hospital, and hospitals present certain risks. So more and more, I'm beginning to see nuance in this discussion, and I think if you can get a colonoscopy at age 50, that's good. I still think on some level that's the gold standard. However, if that is a huge burden for you, these other tests are really nearly just as good, and I think they're fully accessible. So you should have this discussion with your medical team. What kind of clean out can you tolerate? What resources are available to you? What are you willing to undergo to get your colon cancer screening? And go from there. All right, breast cancer screening. Now I told you that some of the decisions handed down by the USPSTF were very controversial, and even if you hadn't heard of that organization, you've heard of these decisions. This is one such area. Several years ago, the USPSTF recommended that we screen average risk women for breast cancer starting at age 50, and we screen them every 2 years with a mammogram until they turn 74, and then finish with the screening. To give you a recent historical perspective, when I was a medical student and a resident, which was within the last 20 years, we used to start screening average risk women for breast cancer at age 40. It's kind of a compromise between ages 40 and 50. We would do a mammogram every other year, and then starting at age 50, we would screen them every year until they told us they were too old to go through the test. What changed? Well, the USPSTF was presented with certain data, and what we know, and this is hard for some people to believe, is that if you screen 10,000 average risk women for a full decade between the ages of 40 and 49, you can save 3 lives from breast cancer. So that's a lot of screening to save not all that many lives. And when we discuss those data, people get very itchy about them, and people can get agitated. And why is that? It's because we all know young women who've had breast cancer, and they're terrible stories. But the data tell us that we don't save that many lives from screening young women. If you screen 10,000 women for a full decade between the ages of 50 and 59, you can avert 8 cancer deaths from breast cancer. And then because we know that breast cancer is more common among older women, if you screen 10,000 women for a full decade between the ages of 60 and 69, well, you can save 21 lives from breast cancer. So the USPSTF had these data, and they made their new recommendations, and a lot of people got very angry about it. So again, how could this be? How could it be that screening younger women isn't really all that helpful from the public health perspective? Well, there's a concern about overdiagnosis. There have been studies, mostly out of Europe, showing that some early stage breast cancers spontaneously regress. And nobody really understands that. But if some cancers you can find on a mammogram one year, and then you do a mammogram the next year and they're gone. And we're very bad at figuring out which cancers will go away and which cancers will go on to harm women. It's counterintuitive, but it's true. There are concerns about early screening. Are we doing anybody good by detecting breast cancers early? And again, this is very counterintuitive. You would say, of course you are. You want to catch cancers early. But what we know is that we started aggressively screening women across this country with mammograms in the 1970s. That's really when that push began. And we have long-standing data. And we know that over the last 40 or 45 years, we have barely reduced the mortality from breast cancer, but we have vastly increased the diagnosis of breast cancer. So we're detecting a lot of new cases of cancer, but not that many women are surviving breast cancer. It's hard to wrap your head around that. And then there are concerns about over-biopsy and treatment. If you take women, particularly younger women who have early-stage breast cancer, and you can't really tell which one of those cancers are going to hurt them, and you treat them all, well, you're subjecting women, some of whom may never get sick from those cancers, to potentially dangerous treatments. Chemotherapy is not easy for people, and it can really hurt people. So anyway, I know this is a technical discussion, but I just wanted to let you all know, because some of you maybe expect mammograms starting at age 40. You go into your primary care doc, and he or she says, no, 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 we're not going to do it until 50. Well, there's a discussion to be had about that, but these are the data upon which your primary care doc is basing that recommendation. Cervical cancer screening. This is an example of a triumph of the American public health system. So cervical cancer right now is a very uncommon cancer in the U.S. There are about 12,000 cases a year, and about 4,000 American women die every year of cervical cancer. And that's 4,000 women too many, but I will tell you that in the 1940s, and I was surprised to learn this, cervical cancer was the leading cause of cancer death among American women. More American women died in the 1940s of cervical cancer than died of breast cancer or lung cancer or colorectal cancer. That's shocking. What happened after the 1940s? Does anybody know? Well, the Pap smear. Right, we got the Pap smear. And at least the women in this room know what the Pap smear is. You know, we can take a brush to your cervix and we can scrape off the outer layer of cells, and we can send them for an examination in the lab, and we look at them under a microscope, and we can tell that some of those cells look ugly or dysplastic, and we can tell based on that that some of them are either precancerous or maybe cancerous, and we can get them early. So the Pap smear came along, and we drastically reduced the number of American women dying of cervical cancer. This is another example of an area in which recommendations for screening have changed since I was a medical student and a resident. When I was a student, we used to start screening with women with Pap smears as soon as they started having sex, and we would screen them basically every year until they were much older. And again, we never really knew when to stop screening women. About 15 years ago, we gained the ability of testing women for human papillomavirus, for HPV, and this virus causes genital warts. It also causes over 95% of cervical cancers, so we can test women for HPV at the same time that we test them during their Pap smear. And so the new recommendations say that we should start screening women at age 21, and if they're low risk, and if we screen them at the same time for HPV and they don't have HPV, well, we can do it every 3 years. And starting at age 30, if a woman is low risk and doesn't have HPV and has had normal Pap smears, we could do it every 5 years. And that should be welcome news to all women. No woman that I know likes getting a Pap smear. No woman with SCI that I know likes getting a Pap smear because it's particularly difficult for women living with injuries. And I'll tell you, when I was in Boston, I just had a normal primary care office. It wasn't particularly accessible. I had a couple of women in my panel who had spinal cord injuries, and I was the kind of primary care doc who did my own Pap smears, and this was an example of somebody with SCI, or maybe two women with SCI, determining in their minds, making a calculation, what am I willing to live with in order to get the health care that I deserve, and in order to avoid having to come back in here for a separate OB-GYN appointment. So I would lift them up onto the table, and my medical assistant would spread their legs because they really weren't able to use my stirrups, my non-adaptable stirrups, and I would do a Pap smear, and it was uncomfortable for everybody involved, particularly for the patients. However, I want to let the women, particularly in the audience, know that there are pieces of equipment that an OB-GYN can easily obtain. They don't cost all that much, that attach to examination tables, and they're kind of souped-up versions of Pap smear stirrups, or bimanual exam stirrups. So this is something you can ask when you're talking to that primary care doctor in that face-to-face, and you say, are the specialists to whom you're going to send me working in accessible offices, or if you call an OB-GYN's office and say, hey, I need some routine gynecologic care, do you have this adaptable equipment to help care for women with spinal cord injuries and other disabilities? Look for this, because they're not hard for these physicians to obtain, and they make your examinations vastly more comfortable. The final cancer we're going to talk about is prostate cancer. And this is another very controversial area. So prostate cancer, it turns out, is very common. There are about 180,000 diagnoses of prostate cancer in the country every year. However, there are only 26,000 deaths per year from prostate cancer. And what you can see is that 70% of those deaths are in men older than 75. So what we like to say is that most men die with prostate cancer, that is harboring prostate cancer, not from prostate cancer. This is another area that was very controversial. So when I was a student and a resident, we started screening average age men at age 50, or average risk men at 50, And we would screen them with a combination of a digital rectal exam. I'd put my index finger in their bottom and I could kind of feel the contour of their prostate gland through their rectal wall. And we would pair that with a blood test called a PSA that maybe some of you have heard of. It's called a prostate-specific antigen. It's a protein that's made in your prostate. In 2012, the USPSTF came out with a strong recommendation and specifically said that we ought not use that PSA blood test for detection of prostate cancer. And you can imagine the firestorm that blew up over that decision. What were the data that went into that? Well, first of all, PSA is a notoriously inaccurate test. So what we know is that this test has a very high false positive rate. So most cases of elevated PSA are not due to prostate cancer. But we also know that this test has a high false negative rate. So there was a very famous study and a shocking study that came out of Europe in 2003, and it was looking at the use of a medication called finasteride in prevention of prostate cancer. And they took a bunch of men, several thousand men, they followed them for a number of years, and they were drawing PSAs on them with some frequency. And at the end of the study, all of those poor men underwent prostate biopsies, even the ones who had always had normal PSA values. And they found that 25% of the men who had had consistently normal PSA values had prostate cancer. So PSA is not a great test. We also know that around 2012, results broke from two major prostate cancer screening tests, one in the US and one in Europe. Both studies followed several thousand men, many thousands of men, over a number of years. Some of the men in those studies had routine prostate cancer screening and some of them had none, and it turns out there was no mortality benefit at all. There was no reduction in death from prostate cancer among the group of men who had been screened. And we also know that no trial has ever proven the effectiveness of that digital rectal exam that I used to subject my male patients to. Part of the downside of screening with PSA has to do with our response to PSA-detected prostate cancers. So it turns out that, Americans are relatively twitchy about our health. We're kind of a phobic people, all of us are. And it turns out that 90% of men who are diagnosed using PSA with prostate cancer seek treatment. And what does treatment look like? It's either a prostatectomy, where somebody opens you up and takes your prostate gland out, or it's radiation therapy. And both of those treatments carry substantial side effects. At least 30% of men who have their prostates taken out who undergo radiation get erectile dysfunction, and at least 30% have chronic urinary incontinence. So these treatments are not benign. So what are we left with? Many of you may ask your primary care doc for screening for prostate cancer, and that primary care doc may say, I'm not going to do it. A urologist may answer differently. We're all kind of left in this dataless space. We're all a little bit confused about it, and it turns out that most primary care docs are now not screening men routinely for prostate cancer, and many urologists are pushing back on that. Studies for the future, or current studies that we're waiting for results from, there are different strategies for managing less aggressive forms of prostate cancer. And one of them is just called watchful waiting. That is, there are men who know that they have kind of low-grade prostate cancers, and we just wait to treat them until they become symptomatic, like if somebody develops obstructive type symptoms. And another strategy is called active surveillance. There's a group of men who know that they have kind of less aggressive prostate cancers, and they go see a urologist maybe once a year, and they get a rectal exam, and they get a prostate biopsy, and we look at the cancer under a microscope, and we make sure that there aren't any significant changes in it. So these are different strategies that we're looking at right now. This is a very difficult area, and it's an area that it's a subject that you can feel free discussing with your primary care team and with your urologist if you have one. Other medical considerations, tetanus shot every 10 years. This is highly recommended. Tetanus lives all over. So it lives on your countertops, it lives in the soil in your backyard, it's on this table. That's why every time you get a cut, somebody asks you if you've had your tetanus shot. Tetanus is everywhere. Tetanus is a very rare disease, but tetanus kills people, and it kills people badly. So make sure you have a tetanus shot on board. Influenza vaccination, flu shot every year. This is essentially recommended for all Americans, particularly for Americans who have what we consider to be vulnerable lungs. So there are people whose lungs are more at risk for infection, for bacterial and viral infection. These are people with diabetes, these are people with congestive heart failure, or with emphysema or COPD. In my book, this includes people with spinal cord injury because very few people with SCI have full lung function. Can't take as full a breath as they used to. They have some decrease in cough, strength, and speed, so they can't protect their airways and clear their mucus as well as they used to. Flu shot for everybody, unless you've had a terrible reaction to it in the past. Same with pneumococcal vaccination, or the Pneumovax. We recommend that every American get a Pneumovax, which helps prevent a lung infection with a bacteria called strep pneumonia. It's kind of a particularly bad form of pneumonia at age 65. Every American ought to get that at age 65. But again, for people with vulnerable lungs, people with diabetes, congestive heart failure, COPD, I think spinal cord injury, you should get once before age 65 and then once again at age 65. So this is something you can bring up with your primary care doc. Say, hey, listen, I know my lung function isn't quite what it used to be. I want that shot. Urology is a complicated story. So there's a very good set of recommendations about urologic management of spinal cord injury. And I've read this article several times, and I cannot see in it that it tells folks with spinal cord injury how often they ought to see a urologist. Most of us who help care for people with SCI suggest that you see a urologist once a year. Why is that? Well, there are many reasons for it. First of all, that urologist may recommend screening for stones with an ultrasound, for kidney stones or bladder stones. Your physiatrist may also recommend that without your having to see a urologist. Why is that? It's because stones can cause autonomic dysreflexia. Stones can become what we call a nidus of infection, so they can gather bacteria, and those infected stones can be a cause for recurrent urinary tract infections. So stones can be problematic. We also know that sometimes people with spinal cord injury develop what's called a high-pressure bladder. Fluid can back up from their bladder into their kidneys, cause chronic kidney damage. We need to guard against that. Most people with spinal cord injury need some form of help draining their bladder drainage and management, and the urologist can be very helpful helping you determine what the safest, most approachable, and most effective strategy for you would be. A physiatrist is also very good at that. But again, Dr. Hoffman has data showing that people even with chronic injuries don't necessarily keep the same bladder management strategy in place year after year. People switch back and forth. So sometimes their needs change, sometimes their hand function changes, their caregiver support. So I think there's a really good reason to see a urologist. One final thing I'll mention, and this is an entirely different conversation, it's a complex one, is that bladder cancer is, in the grand scheme of things, a relatively uncommon cancer, but it seems to be that people with indwelling catheter systems, so people with indwelling Foleys or people with SP tubes, are at slightly higher risk for bladder cancer. It's hard to quantify what that risk is, but a urologist may say to you, if you use an indwelling Foley system every year or two, I want to do a cystoscopy on you. It's like a colonoscopy for your bladder. They'll take a tube with a little camera on the end of it, they'll insert it into your bladder, and they'll take a look around at the lining of the bladder and make sure that there aren't any suspicious spots there. Good reason to go to a urologist. The final subject I want to broach with you is osteoporosis, and the reason I was interested in bringing this up during this talk is because as a physician who helps care for people with spinal cord injury, I'm very bad at bringing this up with my patients. I'm deficient, I stink. But I think a lot of physiatrists share my blame. I just don't think we discuss bone health quite frequently enough with our patients with spinal cord injury. Much of what I'm about to tell you comes from a very well-written review from 2009 by a physician named Kathy Craven, and I've listed this in the references at the end of the talk. Kathy Craven's at University of Toronto. She's probably the international expert on osteoporosis, or bone thinning, in the setting of spinal cord injury. This is what that article tells us. People with spinal cord injury can develop something called sublesional osteoporosis. That's thinning of the bones below the level of your lesion or below the level of your spinal cord injury. And what we know is that by 12 to 18 months after an acute SCI, people with injuries have bone densities below their injuries somewhere between 30 and 50% lower than do what we call well-matched controls who do not have injuries. So people lose bone density very quickly after an injury. We used to think that that bone loss stopped by 1 to 2 years after injury, but it turns out that it doesn't, and more recent data have shown us that many people with SCI continue to lose bone density at a rate of about 3% per year. Why is this important? It's because people with thin bones fracture their bones. And what we know is that between 25 and 46% of people with spinal cord injury will develop fractures, mostly of the thigh bones and the leg bones right around the knee joint. And these can lead to decreased function or increased need for caregiver support or pressure sores or, goodness forbid, amputation. So these are a serious matter. And what we know is that no trials to date have shown reduction in risk of long bone fractures in people with SCI. Now, why is that? It's because we would have to do an intervention on a great number of people with spinal cord injury and follow them for a number of years to really demonstrate a reduction in risk of fracture. So nobody's done a study of that scope yet. We have to do that at some point. What else do we know about the sublesional osteoporosis? Well, I emailed Kathy Craven. She's a friend of mine, and I was like, look, I just read your article. I didn't see anything about screening people for bone loss or for osteoporosis. When, in your expert opinion, do you do it? And she said, I do it between 1 year and 18 months after somebody has a spinal cord injury. Because she said, we know people lose a lot of bone density in those first years and months. She also specifically suggested, and this is something you can bring up with your primary care doctor, there is something called a secondary cause of bone loss. So many people with spinal cord injuries have bone loss below the level of their injuries just because they're not bearing weight anymore, sublesional osteoporosis. But Kathy said that in her series of patients, in her panel of patients in Toronto with osteoporosis, somewhere between a quarter and a third of them have a reason other than the spinal cord injury itself for having developed osteoporosis. Now, what could those reasons be? Well, there could be lifestyle-based reasons. People who drink or smoke a lot can lose their bone density pretty quickly. There could be metabolic reasons, so maybe you have a problem with your kidney and your bladder where you're wasting a lot of calcium when you pee, or maybe you have an overactive thyroid or parathyroid gland in your neck. There could be medications that contribute to bone loss, but she said, again, between a quarter and a third of people in her practice with sublesional osteoporosis have another reason other than spinal cord injury for having lost their bone density. So in that article, she very clearly suggests a workup for secondary causes of osteoporosis, and she suggests that everybody with a spinal cord injury who's diagnosed with osteoporosis have that workup done to make sure that there isn't a reversible cause of bone loss that we can address. There are limited data for treatment of sublesional osteoporosis. There are a couple of studies that have looked at the use of alendronate, which is Fosamax. Some of you have heard of that. It's called a bisphosphonate type of medication, but only in people with Asia A and Asia B injuries. And Fosamax does not reverse bone loss. At best, it slows it down or arrests it. It doesn't give you back the bone that you've lost. And as I said, there are no data yet for fracture prevention. So my recommendation is a little bit wishy-washy. I'd say bring this up with your primary care doc or with your SCI specialist if you're fortunate enough to have one, and say, hey, I want to talk about preservation of bone density, I want to talk about my bone health. And if those two doctors aren't specifically comfortable discussing that, say, hey, refer me to an endocrinologist. Endocrinologists are medical subspecialists. They deal with kind of glandular and hormonal dysfunction. They're very good at addressing osteoporosis. It's their bread and butter. So there's somebody there who can have this discussion with you and help you manage this potential complication. So in summary, I want you to understand your rights as a person living with a disability, and also open a discussion about what you are and are not willing to live with as you seek medical care, particularly clinic-based medical care, understanding that not all clinics are ADA compliant or fully accessible. What can you manage with? What are you willing to live with? I wanted to empower you to set expectations for your primary care physician, and you have to remember that most primary care docs don't know a great deal about the management of spinal cord injury. But that doctor's approach can make up or can go a long way toward making up for that knowledge deficit. So if you have a primary care doc who says, I don't know a lot about SCI, but I'm going to go do some reading and I'm going to make sure that I advocate for you and I fight for you and I'm going to listen very closely to you and I want to work with you to make sure that you get the best and most comprehensive health care that you can, well, stick with that doctor. Know which routine tests and screening tests you ought to get and ask for assurances that referral facilities can safely accommodate you. Again, even if you have that wonderful kind of primary care doc, if all that's available to him or her are inaccessible facilities, that's not helpful to you. And finally, I want to encourage you to keep up with recommendations and with literature surrounding preventative and routine care that you ought to get. Now, there are different online portals that you can use to keep up with that, but the USPSTF website, which I listed in the references at the end of this slide, at the end of this talk, is available to you, and I will tell you that their general recommendations are really written in language meant for lay people. Now, you can dig deeper into the recommendations, you can read their whole reports, you can look at the literature that they pulled in an effort to figure out which tests are and are not beneficial, but their general recommendations, we agree with this test, we don't agree with this test, discuss this test with your doctor, are always written in language that all of us can understand. So thank you all again for having me here this evening, and I think we have 20 minutes at least for questions, and feel free. So the question, in case not everybody heard it, is if you have a complement of physicians taking care of you. Let's say you have a primary care doc and a physiatrist and the urologist on your team, and something comes up, like you think you might be getting a urinary tract infection or you think you might be getting a pressure spot. Is there a rule of thumb that would help you decide whom you should approach first? I have my own bias. I think you should go to your primary care doc first, but I think at a place like University of Washington or the VA, where there are a lot of SCI specialists and they're very available to their patients, I think the reality is that people go to their physiatrist first, and I do not think that's inappropriate. In my practice, I've been very lucky to have substantial backup from a cadre of physiatrists. If I'm in the clinic and I don't understand something, I just grab Rena Reyes and she explains it to me and makes me look smart. So I think the reality is that most people go to their physiatrist first. I mean, do you agree with that, Chris? Or?
Yeah, probably.
And I don't think that's a problem if you have a physiatrist available to you. I think, you know, one of the unspoken issues in this talk is that there are a great many people living in this country who really don't have quick access to SCI specialists, and I think, you know, they rely more on their primary care docs or on whoever is available to them. So the first question was about availability of rehab physicians here at UW, and we have clinics both at UW Medical Center and at Harborview, and there's availability in both clinics. And then the second question was about how to get a seating evaluation, and you can get one either at Harborview or here, and all your physician has to do is put in an order for physical therapy, and then when he or she is filling out that requisition, just specify this is for seating clinic. It's run by the physical therapist here. And they do very comprehensive work, and they'll usually see people within 2 weeks. They get people in quickly. So the question essentially is about potential antibiotic overprescription and the consequences of that, which are development of antibiotic-resistant bacteria. This is an enormous, enormous problem, not only on the individual level, but also on the societal level. We know that there have been strains of bacteria emerging that are resistant to almost every antibiotic we have available to us, and people get very sick from them and could potentially die from them. I think that is a concern from the moment somebody sustains a spinal cord injury. So we know that the rates, let's say, of urinary tract infection, even in the first year after SCI, are really quite high, and people need to be treated appropriately for those urinary tract infections. But I think after somebody's first infection, they have to have very serious discussions with their medical team about how best to prevent them. And we also have to make sure that when somebody potentially has a urinary tract infection, that we're really treating an infection, just not a colonization. And you all probably know the difference between that. Many primary care docs don't. So this is an example of when a primary care doc should be willing to go look up an article for a few minutes and make sure that really you meet kind of the clinical criteria and also the clinical picture of somebody who has a urinary tract infection. And if you don't seem to have an infection, this is where availability of a physician comes in, and he or she should say to you, I don't think this is a urinary tract infection. Let's try, you know, flushing you with liquids, or, you know, changing your Foley, or whatever we think the appropriate intervention is, but say, I'm available to you. If things get worse, you let me know, and we'll give you an antibiotic. But I think this is really a significant concern for people living with injuries.
Supplements. Do you recommend any supplements for people with spinal cord injury, or
No,
anything in particular?
we've had discussions about vitamin D recently, and I think, you know, as I was reading more about osteoporosis and that kind of bubbled to the surface again, I was reminded that vitamin D is very important for helping people maintain bone strength. So I like vitamin D. You can get your vitamin D level checked, and if it's too low, if it's under 30, you can get your doctor to write you a boosting dose over a number of weeks. But there was a lot of discussion in the medical literature, maybe like 6 or 8 years ago, about supplements, and it turns out that most supplements either do no good or actually harm people. And JAMA in particular, the Journal of American Medical Association, did several big articles on that. So I never recommend supplements for people unless there's a specific reason, unless they have like a documented vitamin deficiency.